Hey guys, so today's tutoring is going to be on cardiac dysrhythmias. So usually I split the dysrhythmias with MedSearch 2 and 3. So if your school does MedSearch together, you would have to refer to another video. In this video, we're going to be talking about like the tachydysrhythmias. If you need to go over blocks and the Brady-dysrhythmias, that will be for another tutoring, which will be for MedSearch 3. So for the cardiac dysrhythmias, first off, I want to start off by telling you guys how important it is to understand what a regular cardiac rhythm looks like, a regular sinus rhythm. This is the way that you guys are going to kind of understand when you guys are looking at an EKG if something is missing and what's off, okay? So a regular cardiac rhythm, every beat is supposed to have a P, a QRS, and a T wave, okay? We also have to measure the PR interval and the QRS complex, okay? The PR interval is basically going to be telling us it's going to be more like for the atriums, whereas the QRS complex has to do with how long it's taking the ventricles to pump out the blood. Okay, so the EKG interpretation is something that you guys need to know, and this could come up on your quizzes like a select all that apply. So make sure that you guys know what is something basically the 6 things that you need to make sure that you know and monitor when you're looking at an EKG. So a regular EKG first should be between 60 to 100 beats per minute. Okay. Every R to R interval should be equal. So if you have like a full EKG strip, from every R to R, it should be the same amount of like little squares. Okay. There should always be a P, Q, R, S, and a T wave, like I said. And it is very important for you guys to know how long the interval should be. So the PR interval should be from 0.12 to 0.20, and the QRS complex should be either equal to or less than 0.12, meaning that the ventricle shouldn't take more than 0.12 seconds to contract, okay? And then you always want to look at your ST segment. Your ST segment should always be at baseline. It shouldn't be elevated or below the isoelectric line, because this could if it's elevated, it could be like an MI. A non-STEMI also could possibly lead to an MI, like show that there's an MI. So just know that the ST interval should always be at the isoelectric line. And make sure that you remember that the EKG is basically telling you the electrical components of the heart. It's not actually like, don't get it confused with like heart failure and like the muscle contractions and things like that. Think about electricity when it has to do with ECG, okay? E for electricity. So we're going to start off with your regular sinus rhythm. This is your regular sinus rhythm. So you could see that you could obviously look at the P, the Q, and the RS, the P, the QRS, and the T wave. Okay. Now, when you are assessing the heart rate, what you're gonna do is you're going to count how many R's you see. So in this strip, we have 1, 2, 3, 4, 5, 6, 7, 8. So we have 8 R's, which is the little peaks right over here. Okay, so 1, 2, 3, 4, 5, 6, 7, 8. And you're going to multiply it by 10, which means that this heart rate is 80, which falls in the regular category of 60 to 100. Okay, so this is a regular normal sinus rhythm. This is the rhythm that you want your patients to be having. You could see the P waves, the QRSs, and then the T waves. Okay. All right, so now with sinus bradycardia. Sinus bradycardia is the same thing as sinus rhythm, but now the heart rate is below 60, meaning that sinus bradycardia means that there is still a PQRST, and then the QRS and the PR interval should be normal. It's just that from B to B, it's what's abnormal. So it's below 60. Okay, you see that you have your P wave here, you have your QRS, and you have your T, and then from here to here, it's the same amount of boxes. Okay, so everything is even. It's just a slower rate. So in this strip, we only have 1, 2, 3, 4, 5. So this is the 50 beats per minute. Okay, so heart rate is below 60, but everything else is normal. So the reasons for this could either be normal for the patient. So just because a patient has a 50 heart rate and they have sinus brady doesn't mean that you have to go crazy and the patient's gonna die. This could actually be healthy, like a regular like a regular rhythm for like basically an athlete, someone that runs a lot. So this could be their baseline. Also, when you're sleeping, your body is at rest and your heart rate doesn't have to go crazy. So it could possibly be that it's a little bit slower when a patient is sleeping. But if this is not the case, you also have to look into medications that the patient is taking and any diseases that they have. So if they just had a recent heart attack or have a history of a heart attack, if they have hypothyroidism, uh, if they're on beta blockers, which decrease heart rate, those are the things that you need to monitor, okay? So we could either have a patient that is asymptomatic or a patient that's symptomatic. A patient with asymptomatic, you don't do anything. You just monitor them because they're not showing you any signs and symptoms. Like if their blood pressure is okay, if their respiratory is okay, and it's just their heart rate that's below 50, just keep monitoring them because they're not having any signs and symptoms. Now, if the patient does come out with a heart rate of 50 and then they're also fatigued, have shortness of breath, they're telling you that their chest hurts, things like that, then we do have to intervene. So what we do is that we put these patients on a cardiac monitor and we find out what is happening. So for example, if our patient is on beta blockers, what we're going to do is stop the beta blockers. If the patient has a disease, we're gonna have to give them a medication to increase their heart rate. Okay, so we are intervening in this patient if they have symptoms. If they do not have symptoms other than a slow heart rate, we are not doing anything. We're just monitoring. So make sure that when you guys are taking your exams, you're reading the questions correctly. If the question is telling you that the patient is fine, able to talk to you, is not telling you that they don't have any other signs and symptoms, and the only thing is that you do the vitals and the heart rate is low, you keep monitoring your patient. Why are you going to do anything else? Okay, the patient is not having any other issues. Now, if the question is telling you that you do the vitals on a patient, the heart rate is low, blood pressure is low, the patient is telling you that they have chest pain or they can't breathe and they're having anxiety, then your answer is going to be that you're going to intervene and you're going to put them on a cardiac monitor and you're going to give them atropine. Okay, atropine is usually for your unstable patient. Okay, so if the patient has the sinus brady because of the medications that they're taking, then you're just gonna stop the medication or withhold it. But if the patient is coming out with like a whole bunch of symptomatic issues and they're unstable, you have to give them atropine. What atropine does is that it increases the heart rate. So you do have to monitor your patient because you don't want to put them in tachycardia either. So you're going to start off and you're going to give them a dose of 0.5 milligrams, and this medication is given IV push. Okay? So make sure that you remember atropine is only for your unstable patient. Okay? Unstable only. please make sure that you guys read these questions because they will be tricky, and it's just because you'll be too nervous and you won't read everything fully, okay? So that's why I emphasize read the questions. All right, so sinus tachycardia is just like the bradycardia. Sinus tachy is everything is normal except that the heart rate is above 100, okay? So basically your heart is going crazy. All right, so the reason that this could be is because either the patient has like maybe a fever. If that's the case, you're gonna give them an antipyretic to decrease their tachy. They might be dehydrated, so you're gonna give them fluids. They could be experiencing pain, anxiety. They might have just drank a whole, venti of caffeine from Starbucks. They might have fluid deficit, which is the same thing as dehydration, but it also could be due to drugs or diseases like hyperthyroidism, heart failure, pulmonary embolism, etc. So the medications that could actually cause tachycardia is the one that we just gave for bradycardia, which is atropine, and then of course illicit drugs. Okay, so the signs and symptoms that these patients are going to be experiencing, of course, is like palpitation, shortness of breath, chest pain, and things like that. Usually, when the patient has sinus tachy, they're gonna have signs and symptoms. Excuse me. And then what you're going to do is try to treat everything that you're doing right now is treating the underlying cause before you give them any medication. So if they have fever, like I said, you're going to give them an antipyretic and then monitor again the ECG and then go with that. So if you guys get a question in regards to this, the first thing that you're going to do is treat the underlying cause. Okay? So always treat the underlying cause first. If that doesn't help, then you move on to medications. So you always want to put your patient on a cardiac monitor, of course. And then if you treat the underlying cause or you can't treat it, the medications of choice is beta blockers, okay? Those are the medications that will cause bradycardia, which is the ones that I was talking to you guys about, the beta blockers. So those are the ones that end in law, so like metoprolol and things like that. Okay, so these are going to basically control the heart rate and slow it down. Of course, you always have to check the heart rate before administering these medications. And you're going to hold them if it's below 60. Okay? All right, so the next ones that we're going to talk about is your PVCs. Okay? So a PVC is normal if it happens if it only happens like one time, it's okay. But more than one could be an issue, and 3 in a row could lead to VTAC, which every time that a patient goes into VTAC, they are at risk for going into VFib and then end up in asystole if not treated, okay? So PVCs are very important to be looking out for. Again, if you have one PVC, it's fine. Sometimes we have PVCs, like if we get scared of something or whatever, you will have a PVC. Now, if you have more than one, you do have to treat it, okay? So the causes for this is the same as the sinus tachy, which is good because you guys don't have to memorize so many causes. It's the same thing: fever, dehydration, anxiety, pain, caffeine. The same ones that I mentioned for sinus tachy are the same causes that could cause the PVC. The signs and symptoms, the same thing: palpitation, shortness of breath, chest pain, etc. Now, a PVC has to do with the ventricle, okay? I want you to keep in mind that every time that we deal with ventricles, we're going to be giving lidocaine. Lidocaine is only for the ventricles. So if you guys have a question on the exam and it is not talking about a ventricle issue, then you're not going to pick lidocaine as a medication. That's one that you're going to eliminate because lidocaine is only for ventricles. Okay, make sure that you understand that. Now, what we're going to be doing for these patients is first, we're going to monitor their labs. We have to monitor their labs because we need to look at potassium. Remember that potassium is very, very important and crucial to maintain, because if it's low or high, it could cause dysrhythmias. Okay, so first we want to make sure that we're putting the patient on a cardiac monitor, assessing the labs, and making sure that we look at the potassium. We're also going to be looking at the EKG. We're going to look at to see how this PVC is cooperating with us. Is it similar to one another? Is it happening every other beat, every third beat? How is it looking on the EKG? So your uniform or multifocal means that uniform is that the PVCs look exactly like the same, or multifocal is that they don't look the same. Okay, so one could be up, one could be down. It just looks random. Okay, bigeminy is going to, and trigeminy is going to be what beat is this occurring. So it could be either a uniform bigemini or a uniform trigemini, or it could be a multifocal bigemini or a multifocal trigemini, because a uniform and multifocal is going to tell me if every PVC looks exactly like one another. So if they're both pointing down or if they're both pointing up, etc. Bigemini and trigemini is going to tell you in what beat it's occurring. So bigemini means that every other beat the patient has a PVC. Okay, so if you could see here, this is one beat and then you have a PVC, beat, PVC, beat, PVC. So every other beat is a PVC. Trigemini is every third beat is a PVC. You have two regular beats, the third one is a PVC. Two regular beats, the third one is a PVC. Okay, so that's what it means by bigemini and trigemini, and then uniform or multifocal. So in this case, this strip is going to be a uniform bigemini PVC, and the bottom one will be a uniform trigeminal PVC, because they're both identical to one another. Okay. And then what else do I have to tell you guys about this? Okay, so the way that we treat this is basically giving them lidocaine. Okay. And this is how we're going to treat frequent PVCs. So when you guys are taking the test, make sure that you read. I don't know how many times I'm going to stress this out. Read your questions. And if it tells you that the patient had one PVC, that is okay. A PVC, one PVC. Okay? So if the question says the patient had a PVC, that means it was just one. It's benign. Keep monitoring your patient. It's fine. Whatever. They probably got scared or something. Now, if it says multiple or two or a couple, you know, if it's talking more about more than one PVC, then like you're like, okay, no, cardiac monitor, lab values, check potassium, and give them lidocaine like now. Okay? Because remember, multiple PVCs can lead to VTAC, which could lead to VFib, and then asystole, and your patient will die. Okay? All right. So we don't need this one. All right. So my favorite one is the supraventricular tachycardia. So this one is crazy. All right, so this one, the patient is obviously going to have poor cardiac output because the heart is just pumping, and there's no tissue perfusion because it's just going crazy. So usually for supraventricular tachycardia, it's above 150. Now, I know that you might think that this is your ventricles, but this is not your ventricle. It's called supraventricular because it's supra means above, and ventricle is your ventricle, so it's above your ventricles. And what do we have above our ventricles? We have our atriums. So this is basically your atriums going crazy. All right, so the causes, the same causes as sinus tachycardia. Isn't it nice? And the signs and symptoms are the same thing, just that this patient's palpitations are going to feel like their heart is racing and it's about to come out their chest. Okay, because imagine a heart above 150. All right, so this is very critical. You do have to take, you have to make sure that you assess your patient, because we either have our stable and we have our unstable patients. Okay, and it all depends on how the patient is doing with the interventions that we're going to do. So we're going to put them on a cardiac monitor and we're going to see and assess our patient. If the patient has only the heart rate abnormal and everything else is fine, they don't have any other signs and symptoms, they're telling you that they're fine, they could talk to you, they're sitting up fine, it's just that their heart rate is above 150, you're going to have them bear down. Okay, that's your first step. So this is like by steps. You're gonna begin by telling them, okay, ma'am or sir, bear down. You're gonna have them do that and you're gonna reassess the heart rate. If the heart rate continues to be like that, then we're gonna go on to medication. The medication that we're gonna be giving is adenosine. This is the medication that you guys need to make sure that if you guys don't like learning medications, make sure that you learn. This one is the one that I'm telling you guys that you guys better know from the top of your head and better memorize and understand what it's for and what to do and everything. Okay, this one is very, very important, especially for this exam. Okay, adenosine is only given IV. If the answer choice tells you adenosine PO, you guys better not pick that answer choice, because I swear I'll be so mad at you guys. I'm telling you guys that adenosine is only given IV, okay? IV push only. So do not get thrown off. Do not second guess yourself. Don't ask yourself like, oh no, but I know we have to give adenosine, but it's saying PO. Maybe it was the professor's mistake. No, it's not a mistake. It's there to trick you. They want to make sure that you know that adenosine is only given IV. Okay? So basically, adenosine has like this kind of like effect that it kind of stops your heart for like a few seconds and you basically die. You flatline and then you come back. Okay, so if you look at the patient's monitor while you're giving adenosine, they literally asystole and then they come back. Okay, so there are a few things that you need to know for adenosine apart from it being only IV and IV push. You need to have certain things inside the patient's room before doing this. First of all, you have to have the patient with a large bore needle, IV. Usually they should have two, one on each arm. Okay, one on each AC. You're gonna have to have an ECG monitor, obviously, on the patient. You need to have oxygen at bedside. You need to have a crash cart at bedside, because remember that I'm telling you that this medication basically kills your patient for a few seconds and brings them back to life. Okay, and you don't know if anything could happen, and the patient literally dies. From the medication. Okay, so you have to bring them back. So you want to have your crash cart. You want to put it at the closest port possible, so the AC port. And then you're going to have the ECG, and then you're also going to have the pads placed just in case you need to give the patient CPR and shock them. Okay, you have to have all of that, and you cannot be by yourself. Obviously, you have to have a team. Okay. There has to be multiple nurses or whatever people in the room. You're never going to be alone. Now, adenosine is going to start off with 6 milligrams. Okay? So what you're going to do is that you're going to flush the patient's IV line. You're going to administer 6 milligrams, and you're going to then give 20 cc's of normal saline. Okay? 20 cc's of normal saline after the medication. Okay, make sure that you guys know that. You're gonna monitor the patient. They're gonna flatline and then they come back. If the rhythm comes back as supraventricular tachycardia again, what you're gonna do is you're gonna give them another dose. Now you're gonna increase it to 12 milligrams IV push, and then you're gonna follow it again with 20 cc's of normal saline. Now, if the patient flatlines and then comes back and they still have SVT, then we're gonna go to cardioversion. Okay, make sure that when you guys are taking your exams, you know when you have to synchronize and when you have to defibrilize the patient. Okay, you always synchronize for patients with pulses. So in this case, you have to synchronize and then cardiovert the patient. Okay, and this is all done for your stable patient. We're talking about our stable SVT patient. Now we're gonna move on to our unstable SVT patient. So this is the patient that came in, they have SVT, and they have shortness of breath, chest pain, diaphoresis, anything that you could possibly imagine. We're not gonna tell them, oh, go and bear down. No, you're gonna go all the way aggressive and you're gonna cardiovert that patient, okay? Because this patient is unstable. All right. So the vagal maneuver, the adenosine, and the cardioversion is for your stable patient, and that's in the order that you do it. So if the question tells you, what do you do first for a stable patient, the first thing that you're going to do is bear down or vagal maneuver. Okay. Then if that doesn't work, or if the question tells you, you have a patient that came in with SVT, the nurse already told them to bear down, but they continue on having SVT, what should the nurse do next? Next is adenosine, IV push, 6 milligrams, followed by 20 cc's. You could even have a select all that apply of what you have to have in the room before administering your adenosine. The crash cart, the oxygen, the ECG, the pads on the patient, other people, a team, all of the things that I mentioned, all of that has to be in the room before administering the adenosine, okay? And then if the question tells you that the patient is experiencing multiple signs and symptoms plus the heart rate is at SVT, then you're going to go into more aggressive. You're going to skip the vagal maneuver, you're going to skip the adenosine, and you're going to go straight into cardioverting your patient, okay? All right, so another favorite of mine is Afib. So Afib is also your atriums. So what happens here is that the atriums are quivering. The good thing about this one is that you know that the patient has Afib, because if you could see, the R to R's are not the same. For example, here, this R to R, there's like 1, 2, and like 3 boxes. If you add this little piece and this piece, it's like 3 boxes, right? And then here you could see that it's more wide, and then here it's smaller, and then this one is even more wide, and then this one's smaller. So you see like there's an uneven boxes. So the R to R is not even. And if you remember from what I told you guys at the beginning of the tutoring, that the R to R intervals should be equal. So that's one thing that throws you into knowing that the patient has Afib, because the R to R is not equal, and that usually only happens in Afib. So that could be a test question, because I believe I had one time. It was just like describing like the Afib, and it was just that the R to R intervals were uneven. So with Afib, the thing that you have to consider in this case is that the patient is at risk for clots. So this one comes off a little bit harder for students to notice or like to remember, because there's 3 things that we have to do. Not 3 things, but there's 3 scenarios that we could end up in. Okay, first of all, the reason why AFib could occur is either because the patient had an MI, either they're in heart failure, they had a holiday heart and they started drinking like crazy, if they have CAD, or they have valve disease. Those are usually the causes of AFib. The signs and symptoms, like I said, an irregular pulse, okay, an irregular R to R interval as well. They're going to have palpitation, shortness of breath, and chest pain, okay? So now this is where the tricky part comes in. What are you going to do with the patient? All right, so we're gonna have 3 scenarios. I want you guys, like if you guys are taking notes, kind of like draw like 3 little stick figures. Okay, we're gonna do stick figure number 1. Stick figure number 1 is gonna be named Bob. Okay, Bob came into the hospital, and basically he came in because of, I don't know, I guess he had a surgery planned, right? And he's getting ready for surgery. He seems normal, everything's good, and you do the ECG and EKG monitoring, and you notice that Bob has Afib. Okay, but you notice that Bob's vitals are stable. Bob is not complaining about any palpitation, shortness of breath, or chest pain or anything. You ask Bob if he's ever had any issues, or if they've ever told him in the doctors that he's had Afib before, and he tells you no. So in this case, you have a patient that is stable, and the Afib has probably been less than 2 days. What you're going to do with this is that you're just going to put them on medications. So you're going to place Bob on calcium channel blockers, which is like your cardizem, your verapamil, your nifedipine, your very nice drugs. Okay? You're also going to put them on amiodarone. Amiodarone is an antidysrhythmic medication, so it's basically to treat dysrhythmias. You're going to put Bob on an anticoagulant, either warfarin or heparin. Make sure that you guys know your antidotes. So warfarin's antidote is vitamin K, and heparin's antidote is protamine sulfate. Okay? Always know your antidotes all the time. And then if Bob doesn't get better after these medications, then Bob is going to have to get synchronized cardioversion. Okay? So that was Bob. Bob is good. He's stable. Whatever. We're monitoring. Afib. Whatever. He did all the medications and he did the cardioversion. He's good to go. Figure number 2. This is going to be Billy. So Billy is in the hospital, and he has a history of Afib. Okay, Billy is good. He's stable. His vitals are good. He's not complaining of any signs and symptoms. No chest pain, no shortness of breath, no palpitations. But he has a history of Afib. So we can't really cardiovert Billy, because the reason why we can't do this is because they've had Afib for more than 2 days, and now they are actually at risk for clots, because clots usually will form after 2 days of having afibrillation. Because what happens is that when a patient has Afib, the atriums are quivering, and the blood is kind of like getting stuck there, like it's not moving, so it starts clotting. Okay, so if you cardiovert this patient, you could literally like lead to them getting a pulmonary embolism if there is a clot there. Okay, so you tell Billy that he has Afib, and since it has been more than 2 days, there is a possibility that he could have a blood clot. So we want to cut it you don't want to treat it now. So you're going to send Billy home with the same medications: calcium channel blockers, amiodarone, and then anticoagulants. And you're going to tell Billy to come back in 4 to 6 weeks, because this is going to allow the anticoagulants to work and break down whatever clots and things like that. Okay, now when Billy comes back from 4 to 6 weeks, you're going to do a TEE, the transesophageal echocardiogram. This is before you cardiovert Billy, because the TEE is going to monitor and check the patient and make sure that there's no clot. Okay, once the TEE is negative for clots, then we could do a cardioversion and see if that helps Billy with his Afib. Okay, now we're gonna move on to our third and last patient, Julio. Okay, so Mr. Julio came into the ER. He's very unstable. He has chest pain, palpitation, shortness of breath. He's diaphoretic, anxious. He's feeling like he's gonna die. He's super scared. You check his vitals, and his vitals are like crazy. Radial pulses are not regular. You do the apical pulse for a whole entire minute, and his heart rate is not regular either. So you put them on a cardiac monitor, and you see that the patient is unstable. In this case, you do not care if Julio had Afib for less than 2 days or more than 2 days, or if there's a possibility of a clot. The patient is unstable. You're going to put this patient on a calcium channel blocker drip. You're going to give them amiodarone, and you're going to put them on an anticoagulant heparin drip, and you're going to cardiovert this patient. Okay? So if the question tells you that the patient is unstable with Afib, you do not care about clots. You'll deal with the clots after. You have to save the patient's life first. And then if, God forbid, the patient has a pulmonary embolism, then you're going to have to figure it out. And after, do a chest x-ray and make sure that, you get the embolism out. Okay? So remember that Afib, you had Bob, you had Billy, and you had Julio. Okay? Don't forget them, because depending on which patient you have and you're asked about on the test is what you're going to be doing for them. Okay? All right, so now we're going to move on to the ventricles. So remember what I said about the ventricles, that now anything that has to do with the ventricles, we're going to be giving lidocaine. Okay? So for ventricular tachycardia, basically they look like ghosts. If you draw like little cute faces here, like I think I could do it. No, let me not even try. But yeah, you could have like think about like little cute faces. So you're going to first assess your patient. When you see this ECG, you're going to assess your patient, and you're going to check if they have a pulse or not. If they have a pulse, you're going to synchronize and cardiovert this patient. You're going to give them lidocaine, and you're going to give them amiodarone. Okay, remember that I told you guys, if you have a pulse, you have to synchronize the patient, the monitor. Now, if the patient does not have a pulse, you're going to call a code, you're going to start CPR, and you're going to defib this patient. You're not synchronizing this time. You're defibrillizing this patient because there's no pulse to synchronize. Okay? The monitor is not going to synchronize a pulse because there's no pulse. So you call the code, give CPR, and defibrilize the patient. Give lidocaine and amiodarone and epinephrine. Okay? And that's basically what you do. So the ventricular issues are super easy. You either have a pulse and you cardiovert, and then if you don't, then you do CPR and you defib. So it's pretty basic and simple. I love the ventricles because they're that easy to do. So now for ventricular fibrillation, it looks like this. It looks like, I don't even know what it looks like, but it's basically that your ventricles are quivering. So you're going to assess the pulse. Usually they don't have a pulse. So you're going to call a code, do CPR, defib, lidocaine and amiodarone, and give epi. Remember that epi is for dead people. So that's why you're giving it for patients that don't have a pulse. And then the last one that we're going to talk about is your asystole, which is the one that your patient is basically dead. So you're going to obviously assess for pulse. Obviously, there's not going to be a pulse. You're going to call a code, and you're going to do CPR. In this case, you're not doing defibrillation because there's no there's nothing on the monitor. It's just a line. There's no electrical impulse at all. Okay. In ventricular tachy and VFib, there was an electrical current. But in this case, there's none, so you do CPR and you administer epinephrine. Whenever you have a patient in asystole, you also want to identify the H's and T's, which is basically brainstorming and trying to figure out why this patient ended up in asystole. Was it because they were going through hypoxia, because their potassium was high or low, because of hypothermia, hypovolemia, Was it because of a thrombus, any toxins, tamponade? So you always want to make sure that you assess that, okay? And yeah, that's basically it for the EKG tachydysrhythmias.